The medico-legal misconceptions, we must have a clarity as medical persons in the forensic fraternity department. Now please remember, we cannot tell accurately the time since death. It's a range. Don't ever try to tell 3 hours, 20 minutes for the time for the autopsy being done. Never ever do that. It is only a range. We cannot accurately determine. And please remember, have the courage and courtesy to say autopsy will not always yield a cause of death. Don't ever try to create a cause of death if there is no cause of death. And there's also a misconception that poison is always detected by FSL. If you look at the analysis of the poisons which I've done in the recently last presentation in Ahmedabad, lot of these cases are unwanted. Very often we preserve evidence of viscera when we don't know what the cause of death. And it is compiling and piling a large number. This is causing a disservice to all of us. Let's ensure some quality in forensics. There shall be a minimum standards in autopsy performance, which the forensic fraternity of the academy should decide what shall be the minimum level of competency of performance. Proper documentation. I've seen several autopsy reports in some context or the other. The quality of documentation is very, very poor. Do we stand the scrutiny of law if cross-examined? That's an important element for us. Are we ready to give an autopsy report and stand in front of 10 people, take questions? Are we ready to do an autopsy in the presence of a defense counsel? Do we allow that to happen? If you are strong in your work, if you know your work, you can do autopsy live, because there is no inherent inhibitions on your component for you to do the quality of work we do. And please remember, there should be a specified timeline for autopsy report. If the autopsy report we say 24 hours, even after 24 days, autopsy reports are not going sometimes. There could be exceptions of 24 months sometimes. Okay? And there shall be a peer review process. This is important for us, at least to see we raise the standard, so that people will have respect for the fraternity and we will be safeguarding our profession. Now, let's look into the changes that are going to happen as we evolve from the batch 1920 onwards. There's going to be a competency-based curriculum. Now, forensic medicine has evolved as we have evolved. We have evolved as human beings, scientifically and physically. The evolution of forensic medicine in different parts of the world is a different concept. Whereas we in India are still hanging on to the umbrella of forensic medicine. Whereas people in UK have different specialties like a DMJ in medical jurisprudence or clinical path or odontology or so on and so forth. Whereas we are still stuck with that. But a small change is happening in some centers. People have started doing clinical forensic medicine, clinical toxicology and so on and so forth. So this is a good change, and let's try to improve these things. Now, something somewhere went terribly wrong for us. What did we do wrong? What did things go wrong? Did things go wrong for us really, or did we not do the right thing is a question for all us for introspection. A bad attitude is like a flat tire. If you don't change it, you will never go anywhere. You can't go front, you can't go backwards. This is the picture for some of us like a flat tire. Now, let's look into the issues of a content-based curriculum to competency-based. As I told you earlier, content-based is whatever the textbook is the content for us, depending on the author. My seniors like Nagiredi could have read Krishnan's Forensic Medicine, which was a very comprehensive, small, very easy to understand. Whereas when we read the pictures, we had teachers talking about Narayan Reddy's big book, and we were expected to know anything and everything. But the changes are happening. Now, what are these competence and competencies? Competence is the range of abilities that enables the trainee to do tasks of practice effectively and consistently. Competency is an observable ability of a trainee or a physician. To put it in a simpler word, competency is the ability to complete an acute physical examination. We all are familiar with this, driving a car. In the early part of the driving lessons, we follow traffic rules, low confidence, high concentration, you know where the gear is, where the clutch is, where the brake is, you're looking this way, that way. But as we learn the skills, we will become a competent person. We know when to break the rules also, when to take on the wrong side of the fence, and also high in confidence, and we are in autopilot mode. We are no more conscious. So that is the level of skills we are expected to train our students in the competency-based medical education. In this component of competency-based medical education, the doer alone learns. If you don't do, you will not learn. Let's comprehend that students do not learn sitting in classes anymore, listening to teachers, memorizing assignments and ejecting. Rather, we would like to talk about the learning, write thoughtfully and relate to the past experience and apply to daily lives. Now please understand, let's be the change we want to see in the world. Gone are the days of didactic lectures, it's going to be more of interactive sessions. Are we ready for this? But what are we doing today? Today, we teach them, not facilitate, because we try to cover the syllabus and not uncover. Uncovering facilitates discovery, whereas what we do is something not acceptable. We mug before the class, students mug before the exams, and both of us vomit in the examinations. And all of us happy at the end. This is what is happening. But one question I want to ask you at a later stage of my presentation. We are indulging in spoon feeding. What does spoon feeding lead to? Spoon feeding in the long run teaches us nothing but the shape of the spoon. Are we doing the right thing is the question. This is a time for introspection for us. We have a social responsibility as teachers. We have a social responsibility to nurture students who do no harm to society. That's what I was about to ask you. Are we confident to subject ourselves into the hands of our students when we fall sick is the question. I repeat, if I fall sick, I'm a teacher in this hospital, if I go to the emergency ward in this hospital, do I have confidence to be treated by the emergency room doctor in this hospital? Is the medicine PG good to take care of me is the question. To that level, we should all as teachers make these doctors competent. Otherwise, we are failing, because is it okay to lead these killers onto the road, let them kill anybody but not me? Is the question for all of us. And dear students, when you graduate out, do you have confidence to treat your family members if they fall sick? That is the level of competence. You all shall learn your medical programs and be competent enough, okay? Please remember, as forensic experts, we must be fair and help to provide justice to society. As a part of this small presentation, I want to tell you one example of a document taken from the Royal College of Pathologists of Australia about the clinical forensic training handbook. I'll just take one example and what are the areas we should look into in competence. The traits of a forensic physician includes good knowledge and communication, competency in clinical reasoning, and personal integrity. This is one thing which cannot be procured or purchased in the market, because integrity is something having the character of being honest, reliable, also doing the right thing when nobody is watching us, coming on time when nobody is watching us, doing the autopsy without anybody putting pressure on us. This is all students, are we on time to the class? Integrity is for students is being on time, 8 o'clock or 8:30 at work, whether the HOD is there or not, whether somebody is watching or not. That is integrity. Now, can we buy this in the market is a big question for us. As a part of this, I just want to share with you this presentation, that clinical forensic medicine, what is called as EPS, entrustable professional activity. Some of these are the examples we do in our day-to-day work as forensic faculty. Victim examinations, sex crimes, torture examination victims, injury assessment, age determination, clinical toxicology assessment, and fitness. Now, I'll take this example of a sexual offense examination, SO, which includes triage, consent, photo document, and sample collection, and patient care. Nagiredi Garu, I'm in time. Please warn me 5 minutes before. Okay. Thank you. This what we should know in the component of knowledge includes law should be known to us, an element of law of a sexual offense victim or examination related cases. Law in relation to sex crimes is a requirement. Responsibilities of forensic physician. We should know the pathophysiology of trauma, child growth, role. Child growth is important because child abuse cases we should know is the developmental features okay or not okay, and the role of forensic evidence and forensic toxicology bit of it, and medical issues related to sexual violence is the knowledge component we should know. If you look at the skills component, there should be issue relating consent and prioritizing the needs as forensic medical people in the emergency room, because we are going to take some of these areas ahead of us. Documentation including photography, injury interpretation. Wound should be interpreted properly so that we don't do wrong evidence collection. So evidence gathering and medical assessment and treatment and teamwork with other healthcare. These are the skills a basic doctor should know in terms of interpreting or in assessing a case of a sexual assault examination in the OPD. Now, third element, we saw knowledge, skills, attitude. Attitudes is the most important thing. Approach towards children and adolescents, courtesy towards other professionals, and impartial, objective approach to the case, and provide safety and medical care to the victim, and desire for continuous learning. These are the attitudes. So see, if one competency of a examination of sexual assault case, these are the three components we should